time this evening. Thank you very much.
Thank you. I'm going to take this off so I can speak. I just want to say hi to everybody. As she mentioned, I do work in the field of gastroenterology. Part of the reason that I love my job so much is we really get to help direct treatment and screening protocols for patients and really get to work to maximize patient care. We have the opportunity to educate our patients and really teach them and guide them on colorectal cancer and diseases of the whole GI tract. Tonight, we're going to discuss some of the epidemiology behind colorectal cancer, or that goes along with colorectal cancer, some protocols and screening opportunities, as well as those that should be screened and criterias, testing and treatment options. So without further ado, we'll also discuss possible findings that may occur and how we would treat those findings. So we'll start with a little epidemiology. Why do we care about colorectal cancer? Why does it affect me and why does it affect my loved one? That might be a question you might ask yourself. In 2021, colorectal cancer is the third most common type of cancer in the United States. It stands second only to lung cancer and overall cancer-related mortality and death. In the year 2021, it is also estimated that approximately 150,000 people will be diagnosed with some form of colorectal cancer, and then 50,000 of those people would die or succumb from the disease. These numbers are relatively large and kind of startling facts when you consider that colorectal cancer is one of the most preventable cancers with routine screening, evaluation, and removal of suspicious tissue, otherwise known as polyps. And we'll talk about those a little later. Over the years, there's been a trend upward in the incidence of colorectal cancers. It used to be that it was number 5 in the United States. And as we stated before, it's now number 3. And one would sometimes think that this is only a disease for the older generation to consider. However, there are facts now that say that persons born in around the year 1990 actually have a 2 times higher risk of developing colon cancer in their lifetime and a 4 times greater risk of developing rectal cancer in their lifetime than someone born in the year 1950. Why is that? We don't really have an answer at this point. However, it is certainly thought that unhealthy diet, lifestyle, sedentary lifestyle are to blame for this new trend. And currently, colorectal cancer affects 1 in 23 men, and 1 in 25 women. I'm going to switch this slide. It's okay. So the screening guidelines. There's several organizations that offer us direction and screening guidelines. The American Cancer Society, the United States Preventive Services Task Force, American College of Gastroenterology, as well as the American College of Family Physicians. In the fall of last year, the American College of Gastroenterology developed new screening guidelines and developed the recommendation that we changed the screening protocol from 50 to 70 to 45 persons that are 45-year-olds to 75 years old should be screened with routine screening colonoscopy or a highly sensitive test looking at evidence of signs of cancer in a person's stool. The adoption of this guideline is an exciting thing for us, and we are trying to work to get patients screened earlier. Insurance is still catching up with these guidelines, so we certainly have, I know within the Riverside system, our insurance is covering screening colonoscopies at 45. So recommend that patients reach out to their insurance companies to see if they'll cover these routine screening exams at 45, or certainly come and talk to us and maybe we can offer advice or help on that. So those are the new guidelines. Anyone between 45 and 75 should be screened. And again, insurance adoption is coming on board slowly. It is also recommended that those in good health with a life expectancy of more than 10 years should continue to get screening colonoscopies through the age of 75 or at quick sooner intervals, which we'll talk about in a bit based on previous findings. Those age 75 to 85 should be screened based on their preferences as well as their life expectancy, overall health, as well as any prior screening history or screening findings. Additionally, it is not recommended on a screening purpose guideline basis that anyone over the age of 85 undergo routine colonoscopy for screening purposes. There are some guidelines that also recommend starting screening colonoscopy prior to the age of 45, and who are those people? Those would be people with a strong family history of colon cancer. And when we look at the word strong family history, what does that mean? Strong family history typically involves the degree of the relative to the person that needs to be screened. So a person that has a first degree relative, that would be a mother, father, brother, sister, should be, and they have been previously diagnosed with colon cancer, should be screened 10 years prior to the age at diagnosis of the family member. So, for example, if you had a mother that was diagnosed at 52 with colon cancer, screening guidelines recommend that you be screened at 42. There's also some screening guidelines that look at, or we also look at second degree relatives such as uncles, aunts, and use a combination of possible cancers in that degree line to determine your risk for needing to be screened for colon cancer. And also certain genetic disorders such as Lynch syndrome as well as polyposis or other genetic conditions do require early screening. Those genetic conditions that may put you at increased risk for other types of cancers do require early screening. People that have had a previous history of abdominal radiation or abdominal radiation to their pelvis or abdomen should be treated as well. And I'm sorry, I think my slide says polyps. It should say pelvis. So while these are guidelines, we certainly hope to optimize patient care by making sure we screen at appropriate intervals and have an open discussion with your healthcare specialist or someone like me in gastroenterology that can provide you with the information needed to decide whether to screen or not. With that being said, I always like to put the caveat in there that these are the screening guidelines. Certainly, if you develop any type of symptom, such as rectal bleeding, abdominal pain, blood when passing your stool, weight loss, unexpected weight changes, or any acute, I think we said abdominal pain, those things should be discussed with your healthcare provider or with a gastroenterologist to determine if you need to move forward with screening or testing colonoscopy. So go to the next screen. So the types of screening that are available. When you look at colorectal cancer screening, you can kind of segment the different types of testing into two categories, if you will. One category would be one test, and that category one would be colonoscopy. That is actually the gold standard for evaluation, diagnosis, and treatment of colorectal cancer. While colonoscopy allows us to directly visualize our physicians directly visualize the colon wall. At that time, while they're in there doing the procedure, they can remove any abnormal tissues, they can take tissue samples, and then we would send those tissues off to the lab for further recommendations, and a pathologist would look at those to determine what the tissue is and what should be done with those results. Or we get those results and then we determine what should be done with those results. Colonoscopy does come with some risk. It is their minimal risk, but they should be stated that it is a sedated procedure. So you will get an anesthesiologist that will give you what we call medic sedation. You will not require a breathing tube, but you will be asleep for the procedure. You'll have to have somebody drive you and take you home, get an IV. And then the risk is we are using an instrument to go into the body. So those always come with risk of the possibility of puncture or bleed, but very low risk, but they should be stated. The second group of tests that we were talking about would be what we could consider possibly two-part test. These would be tests that are available, but if they did come back with a positive result, would more than likely lead to the need to do a colonoscopy to actually evaluate what was seen. The first test that is available, or earlier we mentioned, the different types of tests. Fecal occult blood testing, that is something that you would do through your physician. That is done if you're looking at it from a screening perspective. You would do that every year through your physician. It looks for what is called heme. It's part of the blood, and it's just looking for simple. It's a simple test that we do, and it's positive or negative, which shows that there was heme on the card, and that would indicate the presence of blood. The limitations to that test are that it doesn't tell you where the blood came from. So the blood could have come from inside the colon. It could have come from an external source. It's really limited to just knowing that there was presence of blood in that particular sample. Again, usually following up with a colonoscopy, or at least a open discussion with the provider to decide where that blood should possibly came from. Another testing option that is available is a test that is marketed now under the name Cologuard. It is a multi-targeted DNA test. And what does that mean? That's done every 3 years, and a stool sample is sent off to a specialty lab, and they look for the presence of DNA material that is typically associated with changes in the colon that could be related to colorectal cancer. It has a 79% sensitivity rate and a 94% specificity rate. However, a positive finding still requires a follow-up colonoscopy to determine what it is actually seeing. Is that a polyp? And we'll kind of go into that in a few minutes, the different types of polyps and findings. So, and again, it would require a colonoscopy for follow-up in the evaluation of the actual colonic mucosa and removal of whatever was seen. Another possible screening test that exists is a flexible sigmoidoscopy. It can be done under sedation, which is a little different than the MAC anesthesia. And there are actually people that do these without any type of sedation at all. It is less prep than a colonoscopy. Some people don't like the prep for the colonoscopy, so it's less of a prep. It can be done with enemas. The problem or the limitations of the test are that it only identifies it only goes through the left side of the colon. That's the part of the colon before it exits the body. So it goes through the rectum, the first part of the colon, and up the left side of the colon. Or up to the left a little. And if anything was found or anything was seen, we would still most likely have to do a colonoscopy to identify things that are higher up than the flexible sigmoidoscopy. And then radiological tests that exist to types of screening. Those would be tests such as the CT colonography and a double contrast barium enema. So what those are would be these tests are done with radiology, obviously the CT, and the barium is an X-ray type test where where you either ingest or barium is placed in through the rectum. It kind of outlines the colon, gives a picture of the colon. So if they see anything on those tests, whether it be stricture or they see some kind of abnormality or some kind of poaching out, then that would identify maybe that's a polyp or that's something more that still needs to go be looked at with a colonoscopy for evaluation. These tests aren't done with sedation. They do require prep similar to the colonoscopy. Again, they're X-ray images, and it kind of just, again, gives a picture of the colon. But any abnormal findings would need to be followed up with a colonoscopy. So with all that, currently the American College of Gastroenterology recommends that the two best tests for screening for colonoscopy would be the colonoscopy and the FIT test. That's the multi-targeted DNA test looking for signs of DNA evidence of problems in the colon, as well as colonoscopy, which is the gold standard in direct visualization. So those are the two tests that they would recommend. Of course, sorry. The best test is always the test that the patient is willing to agree to and feels the most comfortable with. So certainly coming in, talking about the test, talking about what your specific needs are, talking about your specific health conditions and limitations would be something that we need to consider as well for deciding what test is best for you. In the last year, we've undergone a new battle with COVID-19. And when COVID-19 first occurred, our hospital systems were quickly hit with the need to really identify where our resources were, be prepared to handle influxes of patients, be prepared to handle the proper equipment to keep us all safe and to keep us ready to take care of the sick. And at that point, we actually had stopped doing, for a short time, some of the screening colonoscopies, not diagnostic, not that you'd have a problem. But that has all been lifted now. We are back to doing screening exams. We are fully capable and ready to do those. I feel it's very safe to have these procedures done in the hospital. We have implemented protocols for questionings. They check temperatures. We definitely screen all of our patients and visitors before they enter. So we are back to doing screening colonoscopies in our hospital settings. So that's nice because we don't want to get behind the ball on this. We want to be able to get everybody screened and take care of them. And I think the risk of exposure to COVID, we operate in a separate part of the hospital than what other patients would be. So I think the risk is pretty contained. So let me get my next slide up here. So when we look at, so we do the colonoscopy, and what do we find? We find a quick discussion on what polyps are. Polyps are just small groups of tissue. That's what clumps of tissue. The question is, they can be harmless, and not all polyps will develop into cancer, but all cancer does typically start as a polyp. So that's why we do the routine screening exams to remove the tissue. Depending on the type of polyp or tissue that we find, that will determine the follow-up for that particular polyp. And polyps can range anywhere from, again, benign tissue, which we would call kind of a hyperplastic. It's non-cancerous. It's a clump of tissue that has developed. And those polyps would require a 10-year follow-up. And really, there's no detriment to those type of polyps. As we move along, you look at precancerous polyps. They can be small or large polyps, and those would be something we would call possibly a tubular adenoma. That would mean they have precancerous tissue in them, and those could develop to cancer at some point. And based on their size, the number, where their location, which very little with the location, but size and number determines the next time you would need screening. They determine the time you would need screening for the next, based on the findings of those. Again, doing the colonoscopy, removing the polyp removes that tissue, so it would be gone. Also, other things we find in colonoscopy, we do find cancerous polyps or very, very early cancerous polyps, and sometimes we find cancers in our colonoscopies. At that point, we do like we do with the other tissue samples. We take samples, send them to the lab for pathology to determine what type of cells they are and what the follow-up needs to be. At that point also, we would need to send you over to hematology and oncology once we get the tissue samples, and they could best treat you. So we've covered a lot of information in a short time. And it is very important that we take this information seriously. When we looked at the epidemiology of CRC, colorectal cancer, it is on the rise, and it is not an age-limited disease. Let me change the slide. Put some additional resources and links up here that you can use to find further information. The American College of Gastroenterology, Riverside, has a great website where you can determine doctors you can see in the area, and also has some information on colorectal cancer, as well as American Cancer Society. And two of my favorite public forums to get Google to answer your questions are the Mayo Clinic and the Cleveland Clinic. But certainly always having a conversation with your provider or your specialist. So I want to say thank you for taking the time to listen today. I do have a passion about this topic. I think we're going to have a period of question and answer. And then just want to let you know that here at Riverside, we're here to answer any of your questions and help guide you with any questions you may have or your screening needs. So I guess we have some questions.
Well, thank you. Thank you, Ms. Dishman. This was so informative, and we are so grateful again for your time and effort to put this wonderful presentation together for us. We do have a few questions that came in, so I'm going to read that to you. If you just give me a second,
Okay.
I'll read that for you. Let's see. What if I don't have anyone to take me to my colonoscopy? Can I drive myself?
So you cannot drive yourself. As I said, it is a sedated procedure, so it does require anesthesia. And that would require you to have a driver to take you home. And we typically say that you should have someone be around you to help you for the next 24 hours. If that's just an exhaustive effort and you cannot find someone to drive you, or the person doesn't actually have to take care of you per se. They have to just make sure they get you there and get you home safely. You typically come out of anesthesia very awake, but still have the opportunity to your mind still. I've had a procedure in the past, they say your mind's thinking one thing, but your legs may not be thinking the same thing. So just to make sure that you're safe and that you get home and you're good. In the event that you could not find a driver, that might be the time when we discuss alternate testing. Colonoscopy would be something that we would want to do, but there are patients that do decide to do the fit test based on that information because they can't find the driver. And then that's, again, recommended by the American Gastroenterology that we could do that second test as well.
I have a personal question,
Mhm.
Ms. Dishman. So the prep for colonoscopy is quite grueling.
Mhm.
Is there anything that you can do other than taking the Miralax and the Go Lightly? Are there other types of prep that you can take other than an oral solution?
Currently, that's what we use as the oral solutions and the Go Lightly prep. We can modify the timing that you get those so that you can take those over a longer period of time, or you extend the prep out. People sometimes find it hard to drink 64, the initial 32 ounces of Gatorade and then another 32 ounces, so we can extend the timing out on those. But really, to get a good colonoscopy, we want that colon clean, and those are the best available preps right now.
Okay, well, thank you for that answer. Okay, the other question that came up was, is there any association with sugar consumption and colorectal cancer, or is there anything you can do with a strong family history to ward off possibly getting those polyps and having that cancer rear its ugly head with a polyp?
So just as in everything in life, healthy diet, healthy lifestyle, making sure you're eating the fiber, you're eating the vegetables and the fruit to make sure that you're getting good cleansing of your bowels, and you're having good bowel movements, and just healthy lifestyle things such as vegetables and fruits, freshwater fish, and just the healthy lifestyle, and get up and exercise. The recommendations are 150 minutes a week of exercise. That's about 30 minutes, 5 times a week. And it can be something as simple as going out and walking around your neighborhood. It doesn't have to be a gym membership.
Okay. Well, thank you for that. And then you had mentioned that now younger people seem to be getting colorectal cancers. People that were born in the 1990s are it's more prevalent now than before.
Or their lifetime
Their,
risk. Yeah.
their lifetime
Mhm.
risk.
Mhm.
I'm
That's
sorry.
okay.
So is that something because of our sedentary lifestyle? Is that what your thoughts are, or do we not really know this research yet?
There's no research out that when I was doing my research for this topic and found that statistic, there's no research that has been done yet to actually identify a cause, but certainly I think it trends with a lot of other things we see in disease processes with sedentary lifestyle, processed foods, lack of exercise, unhealthy diets.
All right. Well, thank you so much. Well, we're so appreciative of your time this evening,
Thank
and
you.
we really value everything you do for Riverside, and we're glad to have this great team in Gloucester and in Williamsburg. So thank you so much.
Thank you.